Hello everyone, my name is Minu and my topic for presentation is rehabilitation post intrathecal baclofen therapy. I have seen 3 patients with this implant at the rehab setting that I am currently working in. All were adults, 2 of them were patients with multiple sclerosis and one of them was a 22-year-old patient with CP. All the patients had similar concerns about therapy relating to their new abilities and function after the reduced tone. Their questions encouraged me to dig into the topic more. Hopefully, the information in this presentation will help you clinically. Now, medical treatment options for children with CP have increased in the last several years, especially the interventions aimed at reducing spasticity. Some of the popular interventions were selective dorsal rhizotomy, which became popular in 1980s, botulinum A toxin injections became popular in 1990s, and then of course the orally administered medications like baclofen and diazepam. Intrathecal baclofen therapy is delivery of baclofen into cerebrospinal fluid. It is a relatively new treatment that is gaining popularity. The delivery system consists of a pump, a catheter, and all surgically implanted beneath the skin. The United States Food and Drug Administration originally approved intrathecal administration of baclofen for spasticity of spinal origin in 1992 and for cerebral origin in 1996. Baclofen is a drug which acts as a GABA agonist. The GABA beta receptors are the ones which are sensitive to baclofen and are located in the superficial layers of the spinal cord. So, the administration of baclofen into the intrathecal space requires that the drug penetrate only a few millimeters to reach the receptors. Although oral administration of baclofen also reduces spasticity, the effects are usually mild because baclofen crosses the blood-brain barrier to reach the receptor sites. Higher baclofen doses result in greater systemic effects, the most common being somnolence and drowsiness. Intrathecal administration allows a very small dose of baclofen, which is 1/100th of an orally administered dose, to attain 4 times the concentration in the CSF as compared to the oral dose. Now let's learn a little bit about the pump. The Synchromed pumps are the only implantable programmable devices approved by FDA for intrathecal delivery. They weigh about 6 ounces, 2.5 inch in diameter and 1 inch thick. The reservoir capacity is about 18 milliliters. There are smaller ones available which are 10 milliliters and are around 3/4 of an inch thick. They run on batteries and last for 7 years, after which they need replacement. The cost for the Synchromed pump is around $8,000 according to the research done in 2000. The pump needs to be refilled every 1 to 3 months. It depends on the size, dosage, and concentration of the drug. The whole procedure takes about 15 minutes and it's done by a nurse, a physician, or a physician assistant. Now something about the surgery. The surgery is done with the patient in a sideline position. The surgeon places the pump usually in the right lower quadrant of the abdomen. In small children and in thin adults, the pump may be placed beneath the fascia to minimize the bulge under the skin. As you can see in this picture, a catheter attaches to the pump and the other end is tunneled under the skin around the side to connect to the spinal catheter. The surgeon inserts the spinal catheter percutaneously usually in the lumbar region. The catheter is tunneled through the intrathecal space to the desired point. Typically, it is the mid-thoracic region. Now, this position varies with different researches. Some research say that if you need to reduce spasticity in the upper extremity, it can be in the upper thoracic region, extending as high up to the high cervical region. And if it's in the lower extremity, then you might choose the lower thoracic region and the lumbar region. Most surgeons require children with CP to remain flat in bed 2 to 3 days post-operatively to minimize the risk of CSF leaks. This picture over here shows the external appearance of the pump after it has been placed. A PT is an integral part of the team involved in identification and management of patients receiving ITB. A PT tries to determine whether function, ease of care or comfort would improve the reduction in spasticity. Therapists act as referral sources. Many therapists refer patients for evaluation of treatment with ITB because they are often the family's closest contact to the medical community. Understanding the treatment and indication allow therapists to refer appropriate candidates. With expertise in movement analysis, we bring unique knowledge and skills to examination and evaluation of these patients. Most importantly, we attempt to determine when spasticity is interfering with movement and when a patient is relying on spasticity for stability or movement. In the drug screening trial, therapists document the effects of single injections of baclofen and communicate those results to other health professionals. Concerning direct patient care, therapists become involved directly after pump implantation. In the hospital, safety is an important issue as patients and caregivers learn to deal with bodies that feel and move differently when spasticity and dystonia are reduced. Communicating with nurse or physician managing the dose titration is important to allow the patient to receive an optimal dose of baclofen. Assessment of equipment and determining appropriate rehabilitation services is also important role as the patient moves into rehabilitation phase. Strengthening, improving motor control and monitoring skin integrity and equipment needs are also most often the key components of post-operative therapy. Preoperative physical therapy is rarely necessary for patients with goals of just improved comfort and ease of care. It is recommended for patients with functional goals such as improved ADL or mobility. For patients who rely on hypertonia to sit or stand, strengthening may minimize the possible adverse effects of reduced muscle tone after the pump surgery. Patients with limited trunk control may benefit from trunk strengthening before surgery. For patients who stand for transfers and ambulate, lower extremity strengthening will be beneficial. If strengthening has not previously been a focus of PT, 2 or 3 months of intensive strengthening before surgery seems to help minimize the effects of reduced tone. Now, for immediate post-operative rehabilitation, many physicians require that the patient remain flat in bed for at least 2 to 3 days after implant to prevent headaches and CSF leaks, as I mentioned before. The changes in the muscle tone and movement may make the performance of transfers, positioning and mobility very different for the patient. So, inpatient therapy would include transfer training for patient and the family. Ambulatory patients might need assistive device and supervision until they adapt to the effects of baclofen, and so safety would be a major concern. Seating systems may require minor adjustments, but waiting for a few months for definitive changes in seating and orthosis would be advisable. The usual length of stay post surgery is approximately 5 days, and at this point, the dose should be closely monitored to a therapeutic level. Fine tuning the dose often takes several weeks or months as the patient gains strength and learns new movement patterns. Therapists play an important role in dose titration because they spend time with the patient and may perceive that abnormal tone is interfering with function or care. For example, consider a patient who relies on extensor spasticity for standing. If there is too much baclofen, patient may no longer be able to assist with transfers, and the dosage may need to be decreased. For another patient who is scissoring during ambulation, a higher dosage may be useful. Patients usually begin rehabilitation after 1 month after the pump is implanted to allow for healing. The patients with goals limited to greater comfort or ease of care may not require specific therapy or intervention, as I mentioned before. However, for the patients with goals related to gaining functional abilities like ADL or ambulation, therapy 3 to 5 times per week may be optimal. The intensity of therapy depends on many factors, which may include goals, underlying weakness, motor control, the commitment of both the patient and the family to rehab, and third party reimbursement, of course. Um, so, the recommendation for therapy is individualized to each patient. Uh, Inpatient rehab may be appropriate if patient has short-term goals which are likely to be met within 4 to 6 weeks. Outpatient therapy is the most common recommendation with ITB therapy. For many patients, achieving goals like independent mobility may require months or even years. After an implant, the patient may have different sets of impairments, functional limitations, and possibly different disabilities. A PT should include stretching, strengthening, transfer, and gait training in their interventions. Weakness is often an issue, and learning new movement patterns is often a focus of rehabilitation at this point of time. A therapist needs to evaluate the seating systems to determine if modifications are necessary to accommodate changes in sitting posture or trunk control. Monitoring the skin integrity would be essential as some patients have to sit for longer periods of time. Orthosis also need to be reassessed. Some patients who did not use orthosis before may benefit from increased support at ankle or any other joint, showing decreased muscle tone. Whereas other patients might choose to discard orthosis if the spasticity is reduced and motor control is improved, and if they feel that the support is no longer needed. Now, there are a few precautions with the pump. Normal activities may resume after discharge by the surgeon, usually 2 to 4 weeks after the implant. The pump manufacturers prohibit the use of hot tubs, saunas, scuba diving, and hyperbaric oxygen treatments. Contact sports and activities that may involve a forceful trunk rotation, like karate, are not permitted because the catheter may dislodge and there is a risk of blunt trauma to the pump. They say commando crawling is not a problem, but patients are cautioned not to descend stairs on their stomachs. Driving is restricted for 1 to 2 days after dose increases because of possible drowsiness at the higher dose. Patient may perform all the other daily activities. Swimming is permitted as well. There are some risks associated with the surgery. There might be an infection, catheter breaks, disconnections, leaks and migrations. There might be adverse drug effects or a drug overdose. The signs and symptoms associated with the risk would include warmth, redness, swelling, drainage from incision sites. Overdose is usually rare. If present, presence as drowsiness, confusion, hypotonia, unresponsiveness, coma. A baclofen withdrawal would present with symptoms like increased spasticity, itching, hyperthermia, agitation, and hallucination. There are many benefits of ITB therapy as well. Studies have shown that continuous intrathecal baclofen infusion may be of benefit to patients whose level of spasticity severely interferes with function. It also seems to improve the sagittal parameters of children and young adults with CP. Caregivers report easier care of patients dependent for their ADL, such as hygiene, dressing, and transfers. For the functional group, they report improved gait, transitions, and performance of ADLs. Many patients report greater ease of movement. Now, for both groups, there are reports of speech and sleep improvements, as well as weight gain, which is beneficial for underweight patients. So, as we come to the end of the presentation, let's just summarize the presentation. Of course, the role of physical therapist both pre and post ITB therapy is very important. A PT plays an important role in screening and referring patients for surgery. Now, since ITB is expensive and time intensive and associated with high complication rate, it is very important for a PT to use their unique skills and movement analysis to determine if the impairment is related to spasticity and if surgery will significantly affect the function, ease of care, or comfort. A PT helps to cope with the body function changes post-surgery by improving the strength and recommending adaptive equipments as needed. Studies report that the combination of ITB and rehab has positive effects across the dimensions of disablement. We need to study frequency, intensity, duration, and specific treatment approaches like weight training, biofeedback, etc. We also need to identify outcome measures that are responsive to patients' reports of improvement. Hence, further studies would help gain more information into the topic pertaining especially to physical therapy. Hopefully, this presentation has helped you understand the basics of intrathecal baclofen therapy. The references for the presentation are listed in the next slides. Please feel free to ask questions about the presentation. I'll try my best to answer all the questions. Thank you.